Hi everyone. Today we are going to talk about the third part of the hemiplegia. So we have already dealt with two parts of hemiplegia, how to deal with hemiplegia case. Now we are going to find how to find the level of lesions and everything. The third part. We will go into straightly into the presentation. So we have find out how to find out thrombus, embolus, hemorrhage, how to find whether it is due to ACA, MCA, PCA, and how to tell about the stages of hemiplegia, everything we have dealt with. Now we are going to tell about how to find the level of lesion. So almost level of lesion also we have discussed initially, but now I am going to the detail. So how to find the level of lesion? So the level of lesion, the slope, it may be in the cortex, it may be the internal capsule, it may be in the thalamus, it may be in the midbrain, it may be in the pons, it may be in the medulla, or even it may be in the spinal cord. So such various levels may be there for the cause of hemiplegia. So hemiplegia, we ultimately in the diagnosis we have to probably at what level it may be. So what are the certain clinical features will give a proof that it may be in this particular level. So what will happen when the site of the lesion is in the cortex? And the site of the lesion is in the cortex. Patient will have either motor aphasia or Broca's aphasia, maybe there one. Second, bladder involvement, urinary incontinence will be very common. Third, cortical sensory loss. So pseudognosis, everything may be present. Fourth, denial. So since the cortical involvement is that the patient may have any focal seizures. And the next point is flaccid. Mostly the hemiplegia may be flaccid. The cortical level of the sixth, and it may not be a when a patient to produce a diffuse hemiplegia involving upper limb and lower limb and face, it should be a big lesion. So mostly it will produce a focal, either monoplegia or like those things will be usually present. So again and repeat, when you are going to suspect a cortical lesion and the patient is having motor aphasia or Broca's aphasia, when there's a bladder urinary incontinence, when there's a cortical sensory loss, when there is a fixed focal seizures, when there's a flaccid weakness, and mostly the weakness will be localized to either particular limb, either upper limb or lower limb. Rarely it may be full of hemiplegia, right? What will be the characteristic of internal capsular lesion? Internal capsular lesion, I have told already also, it may be having, patient will be having hemiplegia, contralateral hemiplegia, as well as contralateral hemianesthesia. So hemianesthesia, including the face, patient may be having sensory loss. Homonymous hemianopia may be also be there. Contralateral when there's the left internal capsule, patient may have right homonymous hemianopia, and spasticity will be marked, as well as weakness will also be marked because dense hemiplegia, all the fibers are converged over here. So patient will be having a dense hemiplegia. So mostly the patient will have a dense hemiplegia. Patient will have 0/5 or 1/5 like this, 1 to 2/5. So this will be the power of the hemiplegic side. Thalamus. Thalamus will also have similar feature. Patient have hemiparesis or hemiplegia. The side of contralateral hemiplegia. Patient will also have hemianesthesia. But associated other features are patient may have pain in the hemiplegic side. So when on the history of history taking, when your patient is complaining of weakness, you also ask whether there is any pain. When that's a pain, you suspect thalamic lesions. And another differential point is in the internal capsular lesion, it will be a dense hemiplegia. While in thalamic lesion, it will be a fleeting hemiparesis. The weakness will be only 4/5, 4+/5. So thalamic lesion, hemiplegia will be there, hemianesthesia will be there, but weakness won't be so much marked. It will be like a fleeting hemiparesis and pain, hyperpathia. Pain may be there in the hemiplegic side, hemiplegic area. When there's a pain in the hemiplegic area, always suspect thalamic lesion as the cause. Then Coming to the midbrain, I've already told midbrain have third cranial nerve and fourth cranial nerve. Pons have 5, 6, 7, 8. Medulla has 9, 10, 11, 12. So you just remember, whenever patient is having hemiplegia, along with third and fourth cranial nerve palsy, you have to localize midbrain. So midbrain level, probably the patient is having midbrain. In all these level, midbrain, pons, medulla, it will be a crossed hemiplegia. Patient will having third nerve palsy on one side and the hemiplegia on the opposite side. As well as everything, all these midbrain, pons, medulla, brainstem lesions, all will have a cross hemiplegia. So when the patient has third cranial nerve palsy as well as fourth cranial nerve palsy, that means patient is not able to adduct the eyeball. The eyeball is deviated to one particular side, and patient not able to elevate or adduct or depress. Always suspect probably patient has third cranial nerve palsy, and where you have to see for the weakness on the right opposite side. There is a weakness. It is midbrain level. It's called Weber syndrome. This also we have already discussed. Third nerve palsy with contralateral hemiplegia is Weber syndrome. Benedict syndrome, third nerve palsy with contralateral cerebral tremor or rubral tremor with hemiplegia. You have to suspect Benedict syndrome. So when third nerve palsy, it midbrain level. So Weber syndrome we have already discussed. Claudy syndrome, as I say, third nerve palsy with contralateral ataxia is Claudy syndrome. Level is midbrain. Can see eyeball deviated outside. That means if patient is not able to adduct, patient may not be able to elevate, patient may not be able to depress. All these three movements are because of due to third nerve. So if the eyeball is this side and the patient is having weakness this side, you have to suspect the patient is having Weber syndrome. The patient eyeball is like this, and the patient is having ataxia, you have to suspect Claudy syndrome. So pons, I have told 5, 6, 7, 8 cranial nerve. So if these cranial nerve features are there, we have to suspect these syndromes. Millet-Gubler syndrome, patient will have facial nerve palsy, so 7th nerve palsy, as well as gaze palsy. G for G, Millet-Gubler will have gaze palsy, and patient will have contralateral hemiplegia. I have told all these cranial nerve will be on the same side, but hemiplegia will be on the opposite side, crossed hemiplegia. Foville syndrome, 6, 7. Just a clue. So ipsilateral 6th and 7th nerve plus contralateral hemiplegia is Foville syndrome. So these syndromes are these median part inferior, superior, all these syndromes are there. That almost PG standard, I don't think they will ask you. Coming to the medulla, this also we have already discussed. Medial medullary syndrome. Medulla, 12th cranial nerve palsy in the medial side. So patient will have 12th cranial nerve palsy ipsilaterally and contralaterally hemiplegia. Lateral medullary syndrome. Ipsilaterally patient will have 9th and cranial nerve palsy. Ipsilaterally cerebral signs will be there. Arnold syndrome will be there. Pain and temperature and touch will be impaired only on the half of the face, upper half of the face. Upper half of the face, patient may be involvement. But contralaterally, patient will have impaired pain and temperature over the body and upper limb and lower limb. So this is a typical picture of lateral medullary syndrome. They will have hiccup, dysphagia, nasal regurgitation, everything. So ataxia on one side, same side 9th cranial nerve palsy with Arnold syndrome, with impaired pain and temperature on the upper half of the face. Suspect lateral medullary syndrome. So again, registrating. So midbrain, third, fourth, it will be in present the midline. Pons 5, 6, 7, 8. This picture says this will be midline and this will be somewhat laterally. Medulla, 12th nerve and 9th, 10th, 11th, 12th. So 12th nerve will be present medially and these things will be present laterally. The important picture to localize. This is also somewhat little bit PG standard. So 4 sensory syndromes are lateral. Spinothalamic board, this tracks, all these tracks will be in the lateral, and so sensory will be involved when the lateral aspect of the medulla or everything will get involved. Spinothalamic tract, spinocerebellar tract, sympathetic chain, sensory cranial nerve nucleus. Due to this sympathetic chain only, Patient exam Horner syndrome in a lateral middle syndrome or Wallenberg syndrome. 4 motor syndromes are midline. Medial longitudinal fasciculus. So medially when they involved, patient will conjugate INO like those things. Motor tract of the upper motor neuron, corticospinal tract, medial lemniscus, motor nuclear cranial nerves, all this will be near the midline. MLF, motor tract of upper motor neuron, what is the corticospinal tract, medial lemniscus, motor nuclear cranial nerve. This almost just have a clue, but this is not usually frequently asked in UG standards. So the level of lesion may be cortical, subcortical or internal capsule. This is coronary artery like those. Internal capsule, thalamus, midbrain, pons, medulla, and spinal cord. By having each have a clue, and we can diagnose the level of lesion. So ultimately, at the diagnosis, you have to write probably due to thrombosis involving left ventricular straight branches of middle cerebral artery, and the level of lesion may be at the level of thalamus or internal capsule. That also, if it is the right hemiplegia, you have to tell that left internal capsule. So all this point, right, left, you have to mention correctly. So this is again just cortical lesion, just few points. Usually cortical lesion produces monoplegia. I have already told, because fibers are widely, and the cortical fibers will be widely distributed. So extensive lesion is necessary to produce hemiplegia. So usually cortical lesions produce hemiplegia. Patient have Jacksonian convulsions and headache. Jacksonian convulsion means the fit start in the finger and will go slowly ascend towards the upper limb and face and then become generalized. That's called Jacksonian convulsions. Flexors and extensors of both the upper limbs and lower limbs are equally involved, and also the tones of muscles. Cortical type of sensor loss, example, esthesiogenesis, everything will be there in a cortical lesion. Cortical lesion, we have already discussed. Internal capsule, we have already discussed. One point is that the fibers are densely packed. A small lesion you may produce complete hemiplegia on the opposite side. It will be dense hemiplegia in a case of internal capsular lesion. Brainstem, I have already told, patient will have a vertigo, dizziness, vomiting because all the brainstem are supplied by posterior circulation. So they will have always cross hemiplegia, cranial nerve palsy on one side and opposite hemiplegia. Different side of brain syndromes have been already discussed. Gaze paralysis may be there. People's Horner syndromes may be there. Cerebellum ataxia will be there. All this will be is a common feature of brainstem involvement. So spinal involvement like Brown-Sequard syndrome or any injury over this, patient may not have any cranial nerve palsy, but only the patient will have weakness. So though rare, lesion lying below the medulla, but above the C5 spinal segment. So below C5 means upper limb may not be involved. So above lesion piece would be the above C5 and below medulla. Rare lesion below the medulla, but above the C5 may produce ipsilateral hemiplegia as the pyramidal fibers have already crossed in medulla without any cranial nerve involvement. There is incomplete hemiplegia. So cranial nerve involvement won't be there, but patient will have hemiplegia. So for example, why do you say the internal capsular lesion? You have certain points are there, you can tell. It is known that in a patient, a human type of sound palsy is present on the side of hemiplegia. On the side of hemiplegia, that means patient have left hemiplegia, left human facial palsy, the lesion is in the right internal capsule. So when it is UMN, mostly it will be in the internal capsule. Element type means it will be lower because element will come in brainstem pons, like a pontine lesion will have element type of seventh nerve. So element type of seventh nerve palsy with contrast hemiplegia means the lesion will be in the pons. Hemiplegia without cranial nerve involvement will be there in spinal hemiplegia. So I am ruling out spinal hemiplegia because there is cranial nerve involvement in this patient, sound cranial nerve is there. I rule out brainstem because patient doesn't have element type of facial nerve palsy. In brainstem lesion like pons, medulla, or brainstem lesion, patient will have lower motor neuron type of palsy. So I rule out pons. Midbrain will also be not there because when that's a seventh nerve palsy, midbrain nucleus, midbrain doesn't have seventh nerve nucleus. It contains only third, fourth. So ultimately, the lesion may be in the internal capsule. And the patients are having dense hemiplegia. So I vote in more in favor of the level of lesion probably may be in the internal capsule. Just like that, you have to discuss. The summary of syndromes. So certain times they may ask what is Lachman syndrome, like those. These points you have to tell as a result of somebody called lipopylonetic. This word is often being asked. Lipopylonetic occlusion of perforating arteries. This is the one word that they are expecting in the examination. So lipopylonetic occlusion of penetrating branches produces Lachman infection. The various presentations are pure motor hemiparesis, pure sensory hemiparesis, ataxic hemiparesis, and clumsy and disorder syndrome. Usually they may ask, you have to tell all these four. Just have this remembrance. Pure motor, pure sensory, clumsy and disorder syndrome, and ataxic hemiparesis. So we have discussed how to find thrombus embolus hemorrhage, how to find MCA, ACA, PCA, how to tell about the level of lesion, everything we have discussed. Now, certain points, what we have to do in history taking an examination. So only based on the history, we can diagnose thrombus, embolism, and hemorrhage. We have already told. So these are the points in the past history and everything you have to tell. So you have to tell about past history of TAA or stroke. Patient, when you probe in the history, they'll tell, I had a similar vertigo like those things, and I had a similar ataxia like those things, and I had a weakness, and it recorded within 1 hour, 2 hours. All these episodes, they say, they are telling me it's TAA. So TAA indicative proof, probably it may be a atherosclerosis and maybe a thrombus. So past history of stroke or TAA, you have to ask. Head injury, when there's an intracerebral hemorrhage or EDH, extradural hemorrhage, subdural hemorrhage also may produce hemiplegia. Any sexually transmitted diseases like HIV and everything may also produce focal neurological deficit. History of hypertension is definitely you have to ask. History of diabetes, because these are the risk factors. Past history, these are the 2 points that you have to ask in the second and third point. So you have to ask for any chest pain, palpitation, dyspnea, for rheumatic fever, because when the patient has rheumatic fever, patient may have a atrial fibrillation and patient may develop hemiplegia. So history of fits also we have to ask, because post-ictal transient hemiparesis, when the patient have focal seizures and after focal seizure, when you just examine, the patient may have weakness for few hours. So this is called a Todd's paralysis. Even there is a entity called hemiplegic migraine. The patient have headache and patient may have weakness transiently and they will improve. These are all transient things. When the patient have fever, headache, vomiting, and then convulsions, and then produces hemiplegia, we have to suspect tuberculous meningitis. In TB meningitis, it will cause tuberculous arthritis, and so patient may develop hemiplegia. These things are also very common. Tuberculoma, tuberculous arthritis, tuberculous meningitis, producing occlusion in the small vessels and producing hemiplegia. In the females, always never forget to take history of oral contraceptives, because whenever in the young patient, definitely you have to ask about the rheumatic heart disease as well as the oral contraceptives, because these are the things that are forming the embolic sore. So never forget to ask about the oral contraceptives in females, and that too in young strokes, as well as history of chest pain, rheumatic fever, rheumatic heart disease in females, in patients, in general patients. So fever, meningitis, cerebral abscess, encephalitis, leukemia, lymphoma may produce focal neurological deficit. So chest pain I have already discussed. Atherosclerotic features, any history of recent weight loss, malignancies. Also when there's a secondary in the brain, that also may produce hemiplegia. So you have to just ask these points. The red things are definitely you should not forget to ask. So Todd's palsy usually record within 24 hours. I already discussed. So family history, you have to ask about family history of hemiplegia, because familial, when there's a increased risk of atherogenesis, that also may have hemiplegia. Hypertension, family history of diabetes mellitus, epilepsy, family history of migraine, familial hyperlipidemia, all these are may cause hemiplegia in parents as well as in the children. So this you should not forget. Personal history, definitely smoking and alcohol, you should not forget, because these are the important risk factors for stroke, as well as obesity. Always try to try to tell BMI in the general examination. Calculate the BMI if possible. Height and weight. Just measure the height and weight and just calculate the BMI and write it in the case sheet. It will be a useful point, which may be added risk factor for stroke. So sedentary life, that also you may ask whether he is just a clerk or everything is unofficial, not doing any exercise. So when you are manual labor may not have so much hemiplegia. So general points in the general examination. What are the things you should not forget to mention in the general examination? So where you should tell whether the patient is conscious or cooperative, and you should see by looking at the patient also we can see the angle of mouth is deviated to any particular side. That we can tell even the general examination, because we are just having it for general overall survey. Even in the cranial or pulse you have to tell, but here on looking you can tell. And the directive is how the patient is looking or on the lying on the bed, you can tell. For example, in supine position and bed, the upper limb may be flexed, adducted, and semi-pronated. So a lower limb will be extended, adducted, and plantar flexed. So these are the points. So we can say on examination when you definitely see a case of hemiplegia, one limb will be normal, and other limb may be patient may keep the high hand flexed and adducted, and so semi-pronated, and wrist also be flexed. The lower limb, hip will be extended, adducted, knee will also be extended, and plantar flexed. So these are the points you can see in the general examination and can tell the limbs or what is the position of the patient at present. Always mention the pulse, whether it's regular or irregular, because irregular may cause it maybe due to atrial fibrillation, maybe due to the cause for embolic source of hemiplegia. Always tell about the arterial wall thickness. When the vessel wall thickness is there, it is maybe an added feature for atherosclerosis and thrombosis. So always record the BP in long cases. Better to record both in the upper limb and lower limb. Better to record BP on non-paralyzed limb to avoid low BP due to vasomotor paralysis on the paralyzed side. So record BP on the non-paralyzed side and both upper and lower limb if possible, if time permits. And don't record on the hemiplegic side, hemiplegic limbs. Respiration, temperature, edema, you are all these things usually general things that should not be forgotten. So all the things that have been marked red, you should not forget to mention. Certain times the eye will be deviated to particular side, like those things. That also is try to mention. Don't forget. Even though if you are not able to answer, just the eyeball is deviated to particular side, like those things you will tell, the examiner will be very much impressed. The examiner will be impressed when you pick up findings, clinical findings. When you pick up, you will be impressed. So hemispheric lesions, eyes will be deviated towards the side of lesion in cerebral hemisphere. In pontine lesions, eyes will also be deviated to the paralyzed side. Eyes will be deviated to the paralyzed side. Putamen lesion, loss of conjugate lateral gaze will be there. Thalamic lesion, there will be few deviation. So these are things mostly they won't ask, but just try to mention how that when the eyeball is deviated to particular side, for example, when the eyeball is deviated to right side, you tell that patient is having left gaze palsy. Just mention that the patient is having left gaze palsy. You just identify this gaze palsy, that it itself a very good point. Okay. So you all have will be having notes and everything, how to the scheme of examination, everything. Just write in CNS case, history taking examination is everything. It may be needed for at least 10 to 15 pages. You may need to write. That will be a very good impression in examination. One of the examiner will be asking question and one of the examiner will be verifying the case. So need cases, everything should be is very important. So these things I'm not going to discuss. I will discuss in a separate class how to examine properly in orderly and everything. So you are not to forget, you have to tell about the carotids also. I have told already. So in the hemiplegic case, always never forget to mention about the carotids. Whether carotids is equally fed, you should palpate one at a time. Don't palpate, try to palpate up both the carotids at the same time. So palpate one time, this side and that side, and see whether carotid is equal. When there's a carotid is less volume, you just mention because it may be due to atherosclerosis or thrombus occlusion. As well as you also it over the carotid for any bruit. If you just pick up clinical finding, it will be a very good important finding. Also look for all the peripheral vessels because when that's the embolic source, clot, the embolic may go and occlude any peripheral vessels and patient may also have an absent pulsation. So never forget to mention pulsation in peripheral arteries. Never forget to mention carotids, vessel wall thickening, and everything. Ultimately, another point that you should not forget to mention in the diagnosis complications. The commonest complication is aspiration pneumonia. So whenever patient have a hemiplegia in the initial stage, patient may be slightly altered sensorium and maybe unconscious or everything. So the attenders will try to give something inside the mouth since he is not taking. So they will get aspirated. So always whenever hemiplegic patient suffers from fever and cough, always suspect aspiration pneumonia and never forget to auscultate the respiratory system. And if there is any clubs or anything, bronchial breathing, and just mention. So this diagnosis at the end of the diagnosis, you have to tell about the complication patient is having. Mostly aspirin pneumonia is common only in the acute stroke. So when it's an old stroke, the complications are bed sores like those things. So the complication may be due to immobility, chest infections. Other complications are chest infections, pressure sores, deep vein thrombosis because at the hemiplegic line they are having 0/5, they are not able to move. So patient they may develop deep vein thrombosis or pulmonary embolism. For that only we may be giving heparin as prophylaxis to prevent DVT. Patient may have painful shoulder, certainly even shoulder dislocation is there, maybe there when they are doing severe intense physiotherapy. Urinary infection will be there, constipation may be there, and patient may have a depression and anxiety due to the post-stroke because a patient who is walking normally till now is not able to walk, and so they may develop depression and anxiety. So aspiration pneumonia, chest infections, bed sores and chronic hemiplegia, DVT in acute where the patient is having 0/5 power, where the patient not able to move the limbs, painful shoulder, arthralgia, arthritis, certain shoulder dislocation, urinary infections, depression and anxiety. When these complications are present, just mention in the diagnosis. When there's no complication, it's said without any complications, and then you just finish the diagnosis. So few terminologies in clinical neurology. So hemiplegia, paraplegia, lower limb, both parallel weakness. Diplegia means patient will have quadriplegia like those things only, but lower limbs will be more affected than the upper limbs. It is bilateral hemiplegia of cortical origin. So diplegia means bilateral hemiplegia of cortical origin, where the lower limbs are more affected than the upper limbs. Quadriplegia will be a paralysis of all four limbs, but mostly the weakness will be equal. Both in the upper limb and lower limb, it may be equal. It won't be so much differentiation from lower limb and upper limb. But diplegia predominantly lower limb. When it's a brachial monoplegia, it's paralysis of one upper extremity. Crural monoplegia means paralysis of one lower limb. When right lower limb weakness is alone is there, you have to tell it's crural monoplegia. When the right upper limb is alone there, it's going to contain right brachial monoplegia. There are certain few terminologies certain times the examiners may ask. Cross hemiplegia, paralysis of ipsilateral cranial paralysis, and contralateral hemiplegia. What is cruciate hemiplegia? Cruciate hemiplegia means patient will have weakness on the right upper limb and left lower limb. This is called cruciate hemiplegia. These also they frequently ask in the examination. Cross means cranial or lower motor cranial paralysis plus opposite hemiplegia. Cruciate means hemiplegia on right upper limb, patient have weakness on one upper limb and the other side contralateral lower limb. Like this, it's called cross hemiplegia. Bibrachial paralysis means both the upper limbs will having weakness. When both the lower limbs are involved, it's called paraplegia. When both the upper limbs are involved, it's called bibrachial paralysis. So ultimately, I want to again repeat, diagnosis must, the diagnosis should be corroborated with the history taking and clinical findings. For example, you have to tell a case of acute or recurrent or old CBA, right hemiplegia, right human facial paralysis, probably due to thrombosis involving, you have to tell left MCA, like those things, the opposite left MCA territory. Patient is also having rheumatic heart disease, MS with atrial fibrillation, and other comorbid features like systemic hypertension, diabetes mellitus. Probably in the patient in the stage of recovery, when the patient has reflexes, increased reflexes and everything, and the level of lesion being internal capsule without any complication or with aspiration immunities. All these findings should be there in the diagnosis, and it all the points that are necessary for this diagnosis should be there in history and examination. So few points about the management. Say whenever they after finishing everything, they will ask how will you manage this case. So you have to tell whether you have to do a CT scan or MRI scan, MRI brain, MRA, and carotid vertebral Doppler. CT angio rarely is not needed. So the first thing you have to do is CT scan, because any hemiplegic patient, if they come within 4.5 hours, you can thrombolyze. So CT scan takes only 5 minutes, but when you do MRI scan, MRI brain, it may take 30 to 45 minutes. And because time is brain, each minute when you lose, millions of neurons may die. So first gold standard investigation, when our patient comes within 4.5 hours, you have to do a CT scan. So if whenever what investigation you do, you CT scan brain and MRI brain and MRA. MRA is due to which vessel is being uploaded. So hemorrhage will be measured, seen as the hypertensive area in the CT scan, and input will be in the hypotensive area. So this is typical of hemorrhage, hypertension in the CT brain. Ischemic lesion will be hypo, massive stroke. ACA territory, this is ACA territory, this is MCA territory, everything. Carotid vertebral Doppler is also another investigation to find out any there is occlusion, numbers, everything, stenosis, everything we can diagnose with is carotid ultrasound, carotid Doppler, carotid and vertebral Doppler. ESA we can do, and we can do if there's any stenosis, we can do a stent and everything. Apart from this, we have to rule out any cardiac illness. We have to do ECG, X-ray, echocardiography, because cardiac, we have to rule out any embolic source is there for hemiplegia. We have to do lipid profile, because lipid profile is the must investigation in case of stroke. And when it's a stroke, we have to do an ANA for SLE, ESR, CRP, ANCA for vasculitis, to rule out ANCA, to rule out vasculitis disorders, especially in young strokes. So young stroke, these are the investigations that is very commonly to be told whenever a patient comes with a stroke less than 40 years. So whenever the patient is having less than 40 years and having the stroke, you have to tell that we have to assess for protein C, protein S levels, PT, APTT, platelet count, ESR, CRP, ANCA, lupus anticoagulant for ruling out antipulpit antibody syndrome, ANF to rule out SLE. Other factors apart from the investigation, treatment aspect, you have to all minimize the risk factors. For example, you have to stop smoking, you have to treat that with good glycemic control, BP should also be good control, you have to reduce the cholesterol drugs. The important drugs we have to give is antiplatelet drugs, we have to give aspirin or clopidogrel. Usually anticoagulants, heparin doesn't have a role unless the patient is having atrial fibrillation and clot is there, or the patient is having DVT, you are giving for DVT prophylaxis. When the patient has 0/5 power hemiplegia, the patient is not able to move limb, we are not able to move limbs, then you can give heparin as a prophylaxis for DVT. So treatment, aspirin, clopidogrel is the first thing you have to tell. Then you have to tell glycemic control, blood BP control, cholesterol control, smoking should be stopped. All those things you should not forget to tell. When the patient is unconscious, you have to tell about the ABC, airway, breathing, circulation, and everything, hydration, nutrition, and everything. So These things certain time exam. So even it's a ischemic stroke, maintain BP. When the patient comes within 4.5 hours, you have to treat the BP only when the BP is more than 220, 110. Otherwise, you should not reduce the BP. When it is hemorrhagic stroke, try to reach the BP 160, 80. When the patient is hypoglycemia or hyperglycemia, you have to treat both the things. But because hypoglycemia is so mimic. Temperature is there, you have to give antibiotics. So if we a stroke, with each minute delay, millions of neurons will be lost. Time loss is brain loss. So you should not delay in a case of stroke. Early management is important. This is fast. How to find early to find out any case of stroke. Patient fast means acronym for facial weakness, arm weakness, speech difficulty, and time is brain. When these things, three things are there, you have to act very fast, and we have to call 108 and everything, and we have to ready thrombolize. So the thrombolytic agent is called antiplase. That is one drug that is available all over the India, and another drug we can also use tenecteplase. So antiplase we can use, and tenecteplase is the dose. So the dose is 0.9 milligram per kg. 10% of the dose can have to be given bolus, and rest you have to give over IV infusion over 1 hour. So acute stroke within 4.5 hours, you thrombolize with IV antiplase. Patient comes after 4.5 hours, you have to give antiplatelets and everything. Antiplatelet means aspirin, clopidogrel, everything. Apparent doesn't have a good any role. Only patient when the patient is giving, you are going to give only for DVT prophylaxis. Okay. Aspirin 300 milligram single dose to be given immediately, followed by 75 milligram or 150 milligram daily, along with clopidogrel. When you give it along with clopidogrel, aspirin 75 plus clopidogrel 75. When the patient having severe cerebral edema, massive stroke patient may have cerebral edema, at that time you have to give 20% mannitol IV QAD to reduce cerebral edema. You can also give oral glycerol. It is also anti-edema drug that will reduce the cerebral edema. You can also give 3% normal saline, hypertonic normal saline. That will also reduce the cerebral edema. So there are for reducing the cerebral edema, there are mainly 3 to 4 drugs. One is mannitol, 20% mannitol, 100 ml QAD, oral glycerol. You have to give. Another is 3% normal saline, and rarely you can use even diuretics also. So ultimately, after hemiplegic acute management, we have to give rehabilitation. So physiotherapy, occupational therapy, that also don't forget to mention. This is just our ideal line of management you can tell. So when a patient of hemiplegia has come, put in the railed cot, insert rails tube, hold catheter bladder drainage, you can tell all those things point in the exam. But how will you manage if they after telling the investigation? So you have to introduce rail tube when the patient is not able to swallow it properly and everything. Patient is of semi-consciousness. Do Foley's catheter when the patient is not able to walk. So patient may pass urine, it may produce infections. Nursing gas, pulse, half an hour PTR, give antibiotics, give oxygen, give paracetamol if there is aspiration, suspected aspiration pneumonia, treat cerebral edema by 20% mannitol, or either give oral glycerol, teaspoon 3 times daily, or even you can give furosemide. You have to give good glycemic control. BP, I have already told. So when you are going to thrombolize, the BP target is 220, 110. Only when the BP is more than that, you have to reduce the BP. When you are not going to thrombolize, the BP target is 180, 110. Not going to thrombolize means 180, 110. Never try to lower the BP beyond that. When you are, again it tells, when you are going to thrombolize, the BP target is 180, 110. When you are not going to thrombolize, the BP target is 220, 110. So aspirin, diprodamol, diclofenac, or the other drugs we can give as an antiplatelet drugs. So 300 milligrams immediately, followed by 75 to 150 milligrams, clopidogrel 75 milligrams. So when you are given IC, when you are suspected hemorrhagic stroke, never try to mention aspirin. So don't think aspirin as a routine. So when it's a ischemic stroke alone, you have to give aspirin. When it's a hemorrhagic stroke, when you give aspirin, it may aggravate further bleeding. So have a cautious in telling aspirin. You have to give when the patient has dense hemiplegia, you have to give water bed or air bed to prevent bed sores. And cholesterol, ultimately cholesterol lowering drugs like statin, atorvastatin, rosuvastatin, never forget to mention. When the patient has atrial fibrillation, we have to treat the valvular heart disease and we have to give digoxin, verapamil, like those things to control the ventricular rate. These also. So acute treatment is RTPA. When the patient has massive MCA stroke and the patient has massive cerebral edema, so that time we can do decompressive craniectomy, decompressive craniectomy, and so the edema will get dissolved. We are relieving the cerebral edema, and patient we can save the life of the patient. When the patient have carotid TIA and carotid severe occlusion, we can do carotid endarterectomy. These are the two roles of surgery. So surgery means decompressive craniectomy in massive stroke and also decompression in posterior circulation stroke when there's a massive cerebral hemorrhage, and carotid endarterectomy in patient with carotid TIA or other stroke. Physiotherapy is also very important. So these are the various risk factors of stroke. All these things should be used to ask in the history or examination: hypertension, diabetes, hyperlipidemia, smoking, obesity, cardiac diseases, carotid, OCPs, high alcohol consumption. Is there any hyperviscosity syndrome like polycythemia, thrombocythemia, trauma, family history? All these are important risk factors for stroke. So they are told when the patient is less than 40 years of age, these are the various important causes. One is cerebral embolism, cardiac sources, or OCP pills, subarachnoid hemorrhage, rupture of perianeurysm. Because when the patient is a young stroke, they may be asked about what are the probable etiologies. So you just try to bygauge this and try to tell. So arthritis or vasculitis disorders like tuberculosis, syphilis, tuberculosis disease, and connective tissue diseases may produce vasculitis and may produce hemiplegia. Hyperviscosity syndrome like polycythemia, thrombocytosis, demyelinating disease like multiple sclerosis may produce young strokes, intracranial neoplasm, and meningitis, encephalitis, tuberculosis meningitis, and everything may also produce stroke in young. You just never try to forget this and have this. Whenever patient young stroke you have to give, patient is being given, you have to suspect these diseases as positive. Other than this, hemiplegic migraine, anticoagulant therapy, abscess, tuberculoma, these things you should not, but this is the 5 points that you mostly they will ask. So young stroke procoagulants listed like protein C, protein S deficiency, antithrombin 3 deficiency, hyper and homocystinemia, activated protein C, resistance factor 5 laden mutation, prothrombin mutation, and antiphospholipid antibody syndromes. These are the important causative for risk young stroke, and all these levels should be assessed. So remember this, and when the young stroke is there, you have to tell all these levels should be protein C, protein S levels should be there, antithrombin 3 levels, homocysteine levels, you have to see activated protein C, factor 5 Leuden mutation is there, or you have to see all these antiphospholipid and lupus anticoagulant antibody test. All those things should be done to diagnose all this young stroke. So I told all the investigations are very important to rule out young stroke. Thank you for patient listening. And how to examine a CNS case? How to what are the things? What are the order in which we have to examine? How to examine training or how to examine the tone, reflexes, everything. I will deal in the next my video. Thanks a lot. Thank you. So in examination, whenever a case of hemiplegia is being given, try to jot out the diagnosis as I have mentioned and may record all the points needed in the diagnosis, in the history taking, and in the examination. Definitely, because mostly examiner will treat, one of the examiner will be seeing the case sheet, how you are writing. So the case sheet will be minimum of 8 to 10 pages. You will just try to write and have a frequent writing of cases, then only you can finish, because you will be given only 1 hour. Within 1 hour, you have to examine and we have to write the case sheet. And all those, it won't be possible unless you write a frequently a case sheet. It will be, you can examine the case as well as you can write the case sheet within 1 hour and can be ready for presentation. So wish you all the best. Thank you.